This actually, and this is in the placebo where there's no response to insulin as expected. But in these patients that were infused with GLP, there is an increase in insulin. Okay? But as the blood glucose starts to come down, the insulin levels also starts to come down. And the reason being is that this is in terms of the glucagon levels, where this is placebo infusion, where there's no change in the glucagon levels, but with the infusion of GLP, there is an initial decrease in glucagon levels, but as the blood glucose becomes lower, then the glucagon starts to go up, i.e. the GLP now will stop the secretion of insulin as well as now release the inhibition of glucagon. That's the reason why the blood glucose levels will remain about normal and not go down to the hypoglycemic range. Hence the so-called the glucose-dependent effect of GLP action. Right? And the other question is that how long does the GLP infusion, GLP needs to be around for it to have the effect? This is another experiment where GLP were infused for about either 16 hours or 24 hours. Okay? In the same subjects that had GLP infused for 16 hours, there was a reduction in plasma glucose, as expected with the GLP infusion. This is with before the treatment, before GLP was infused. This was before, and this is about 7 days after GLP infusion. But immediately after the cessation of GLP infusion, the blood glucose starts to rise, so that about 4 hours following the stoppage of the insulin infusion, the blood glucose remains almost unchanged or identical to pre-treatment. But if the GLP were infused over 24 hours, then the blood glucose remains significantly lower throughout the 24 hours. Hence, you need the GLP to be for at least for 24 hours for the effect to be seen. The moment you stop, the GLP is no longer in the circulation, the blood glucose will start to go up. Hence, the importance of GLP to be maintained for at least 24 hours. Right. The next question is, when you talk about, as I've been mentioned previously, GLP stimulate insulin. At the same time, it decreases glucagon secretion. Which is more important? Is it the insulin secretion or is it the glucagon suppression more important as far as the effect of GLP-1 is concerned? So, right, so this is the other studies show that, as I mentioned, when GLP is given, there is a rise in insulin levels, okay, mainly due to increase in peripheral glucose disposal as well as decrease in hepatic glucose production. Okay, and at the same time, okay, there is an inhibition of glucagon secretion, okay, with time, and hence leading to decrease in hepatic glucose production. Okay, and the recent study, okay, by Jens Holt's group to show that both these two effects are equally important. Okay? That not only the increase in insulin secretion, but also the suppression of glucagon secretion is also important as far as the glucose lowering action of GLP-1 is concerned. Right, we want to go on to talk about the other effects of GLP-1. Right, the other effects of GLP-1 directly on the beta cells is that it can decrease beta cell apoptosis or beta cell death. It can lead to increase in beta cell neogenesis. It can increase in beta cell proliferation. This is neogenesis, formation of new beta cell. This is getting new beta cells. Okay? And it can decrease to new beta cell hypertrophy. And all this will lead to beta cell regeneration and increase in mass. So you get the increase in both function and also in mass. Right. Now, looking at the effect of GLP-1 on beta cell function, this is a study where subjects were infused with saline or with GLP-1 over 6 weeks. In those subjects that diabetic patients, who had saline be infused for 6 weeks, there was no change in the C-peptide concentration, which is a marker for insulin secretion, either week 0, week 1, or week 6. But in those diabetic subjects who were infused with GLP-1, this is at baseline, week 0. This is at week 1, where there is an increase in C-peptide concentration, and this at week 6. Okay? Hence, over time, there is improvement in beta cell function. Hence, the effect seems to be additive, right? Over the 6 weeks. The other effect, which I don't have time to go into, is that GLP have other effect other than on the pancreas. Okay? There are some studies to show that as far as the heart is concerned, it can give rise to protection and improve function. On the stomach, there's decrease in gastric emptying and decrease in acid secretion. Into the brain, there is increase in learning and memory function in animal studies. Also, animal studies, there's some degree of neuroprotection. There is increase in satiety and leading to decrease in food intake. So hence, these are the other so-called extra pancreatic effect of GLP-1. Okay. And apart from that, the other postulated effect of GLP-1 on the cardiovascular system, on the heart, there is increase in glucose uptake through this mechanism, and can also activate anti-apoptotic kinases. Okay. On the vascular system, there is increase in nitric oxide dependent vasorelaxation, and also reduces TNF-alpha mediated secretion of PI1 by cultured endothelial cells. And on the kidney, there's increase in diuresis and sodium excretion in response to sodium overload. So these are the other so-called extra pancreatic effect of GLP-1. Right. Next, we go to the incretin therapies and pharmacology of liraglutide, which I think Dr. Simpson will go into some of the clinical studies of this. Right. The so-called insulin-based therapy, incretin-based therapies. When this is in terms of what are the sort of pharmacological agents that we have for incretin-based therapies. We have the ascending-based therapies such as exenatide, based on the Gila monster saliva, extending 4. Okay. GLP-1 analogs such as liraglutide. Then these are classified as GLP-1 receptor agonists. Then you have the DPP-4 inhibitors such as the gliptin, sitagliptin, vildagliptin, then saxagliptin, and all the other gliptins coming in. These are basically inhibits DP4, inhibits the breakdown of GLP-1s, and hence you enhance the levels of physiological amounts of GLP. Okay? And this is what we call as incretin-based therapy as a modality of treatment for type 2 diabetes. Right. Liraglutide is based on some modification to the native GLP-1. As I'm sure you've heard yesterday, GLP-1 is a very short half-life because it's being degraded quite quickly by the DPP-4 enzyme. Hence, for liraglutide, what was done was that there was a change in lysine here, was replaced by arginine. The reason being because to this lysine, glutamic acid was added to this glycine, where the C16 fatty acid palmitoyl is bound to this glutamic acid. Hence, if this glutamic acid were to be present there, okay, this lysine were to be present there, then the glutamic acid will also, the C16 palmitoyl acid will also bind to that, and hence you have two fatty acid change which will disrupt the action of this molecule. Okay? So hence, there is only 97 amino acid homology because you only change two amino acids, arginine here in place of lysine, and get glutamic acid bound to this lysine. Okay? Right, and as the drug subcutaneously, which is in the form of haptamer, okay? But as it can resolve slowly into monomer, which is bound by albumin and hence gets circulated to where it will work. Hence the so-called the slow release of the GLP-1 agonist. This is to show in terms of the pharmacokinetics of GLP of liraglutide, where the first dose is given here, and this is the level of liraglutide, where the half-life is around about 12 hours, and the slow degradation of this peak is about 12 hours, okay, and half-life is about 2.5 days, okay, and the slow excretion of liraglutide. But the first day 5 is given again, but after about 3 subsequent doses, then the levels becomes almost identical. Steady state is reached after about 3 doses of liraglutide. Okay? Hence the once daily dose of liraglutide. Okay? This is the effect of a single dose of liraglutide and beta cell glucose sensitivity. In this study, subjects were infused with glucose and to maintain a certain amount of blood glucose and response to a dose of liraglutide given 6-9 hours before this study. Okay? In those patients that were given placebo, there was an increase in insulin secretion because the blood glucose actually goes up. So that's why you have some insulin being released. This is in healthy control where the insulin secretion is markedly increased as compared to diabetics given placebo. But in those diabetic subjects who were given liraglutide, the insulin response is almost normalized, okay? Like normal as compared to those that were given placebo. Hence, that the dose of liraglutide restores more or less the insulin beta cell glucose sensitivity. Right? This is looking at the first phase insulin secretion and the maximum beta cell insulin secretory capacity. So in this study, where subjects were given used under hyperglycemic clamp, where in response to liraglutide, this is in response. This is for placebo or normal saline, okay? And this is liraglutide. There is an increase, restore of the first phase of insulin response in response to a hyperglycemic clamp. Right? Whereas in those that were given placebo, there is a small rise. But when arginine is given, which is a potent stimulator of beta cell, the response is markedly increased in those that were given liraglutide as opposed to those that were given placebo. Okay? Hence the restoration of the first phase insulin secretion response and the maximum beta cell insulin secretory capacity. On the other aspect is looking at the suppression of glucagon secretion, whereby this is those that were given placebo, and throughout the 24 hours after either placebo or liraglutide is given, there is significantly lower glucagon as compared to those that were given placebo over the 24 hours. Okay? And when the blood glucose is low, there was also no suppression of glucagon during hypoglycemia, i.e., the liver is able to respond to low glucose, and because this is not suppressed. Okay? Right. This is another study looking at the insulin secretion in response to low plasma glucose, whereby patients were given insulin, subjects were given insulin plus glucose, okay? And the glucose level was maintained at the 4.3 at these levels, and as the blood glucose actually comes down, in those subjects that were, when the blood glucose was higher, there was increased significantly higher insulin levels compared to those that were given placebo. But as the blood glucose comes down to 2.3, then the rate of insulin secretion is almost identical to those given placebo, i.e., there is no stimulation of insulin release when the blood glucose is actually low. Right, so in summary, as far as GLP-1 is concerned, okay, GLP-1 is a 31 amino acid peptide, which is secreted in response to meal ingestion, but the native GLP-1 is rapidly degraded by DPP-4. Okay? GLP-1 must be given continuously to realize its therapeutic potential. I.e., as mentioned, you need 24 hours of GLP-1 for it to have any effect. Right? GLP has other desirable effects, such as it lowers blood glucose effectively. It can improve beta cell function. It reduces body weight. Mainly, one of the reasons is because of delay in gastric emptying, but of course it also has effect on satiety. It has potential to halt disease progression based on the some of the studies that have been done as far as the so-called extra pancreatic or extra gastrointestinal effect of GLP-1. Okay? And GLP-1 has had some beneficial effects on the CV, CNS, and GI systems. For liraglutide, then it provides pharmacological levels of GLP-1, has been shown by the studies, and there's less peak-to-trough variation as compared to exenatide, which I didn't show in this study. And there is increase in beta cell sensitivity to glucose. It can also increase both first and second phase insulin secretion, as shown by some of the studies earlier. The effect on glucose lowering is very much glucose dependent, i.e. when the blood glucose is low, there is no further lowering of blood glucose because there is inhibition of insulin release, as well as the no suppression of glucagon secretion. And it also suppresses glucagon. That's the other effect. And hence the liraglutide is the first once daily GLP-1 analog and has benefits of not only glucose control, but possibly, because I think Dr. Simpson will be talking later, that weight reduction and also has some effect on blood pressure reduction. Okay? So with that, then I think we'll move on to the second speaker, who will talk on the liraglutide, the evidence and place in therapy. Dr. Richard Simpson is currently the principal investigator for diabetes trial in the Eastern Clinical Research Unit and based in Box Hill Hospital in Monash University. He's an author of over 40 research papers and has been in clinical practice, both private and public, for the last 20 years in the area of diabetes and endocrinology. Dr. Simpson's major interest is in understanding endothelial action of glitazones and GLP-1 and management of gestational diabetes and in the prevention of type 2 diabetes. So I'd like to welcome Dr. Simpson to deliver his talk on liraglutide, evidence and place in therapy. Dr. Simpson, please.
Thank you, Dr. Mohammed, for that introduction. And thank